When Dr. Canio and I first met years ago, she said she was really interested in putting together a Caregiver 101 class, kind of a class for family members of patients that are seen in our department so that we can help family members feel more equipped to be on this caregiving journey and more empowered to get resources and support for themselves, because everyone wins in that scenario. So today we have about 90 minutes to cover a lot of territory. We're really just meaning to touch the tip of the iceberg in this class. This is just kind of what do we think folks ought to be aware of, not with a goal of you leaving and the world is suddenly changed after having come to this class today. We simply don't have time for that. But really just having you be informed of what we think family caregivers ought to be aware of, what ought to be on your radar screen. If you leave today understanding there are resources here at Kaiser and in the community that could be helpful to you, and if you leave today with a little bit of an understanding around how and when to tap into those resources, I will feel like this class has been successful. That's a realistic goal for this class. So the curriculum for this class is actually a curriculum that I developed with a colleague of mine at Redwood Caregiver Resource Center, and they allow us to continue using this format. Each of these 8 bullet points are actually topics for an 8-week series we put together for caregivers of people in the early stages. So what do we think as folks are starting the journey? In fact, the class was called Starting the Journey. So all of these topics could definitely warrant 2 hours each in terms of the time we allot to them. For purposes of this class, we're just going to really kind of survey the land. And if you want more information, I have information up here on different resources. I'm available, our whole team is available, and our community partners are also available. We'll talk more about that. Okay, so welcome everybody. Anybody have any questions or anything you want to bring up before we get started? Okay. So in the years that I've been working with family caregivers, in my experience, and really with anything that's new, when we have to cultivate new coping strategies, it's really important to have context. If we don't know what we're working with, it's really hard to know what the right thing to do is. It's really hard to have a game plan when we don't know the game. So all of you today, I'm assuming, have come through, had your loved one have at least an initial evaluation with one of our doctors, and you have a little bit more information about what's going on with your loved one than before you came to this clinic. It's not uncommon for me to hear that folks have been having a frustrating time trying to figure out what's going on, because in the early stages, as folks are beginning to have dementia symptoms, those symptoms can be kind of elusive. And for a long time, the primary caregiver is often feeling really isolated and disenfranchised in their experience of these changes. And what I mean by that is the rest of the world doesn't often notice for a long time. So the folks who are closest to the person who's having the symptoms are usually the people who are noticing what those changes first and kind of describe feeling like they're out in the wilderness calling out, something's wrong, and nobody's listening. Any of you, I see some nodding heads, any of you have that situation either with other family members or friends or even some medical professionals? Dementia is a steep learning curve, and it's not uncommon for us to hear, you know, Kaiser has a pretty good system in place now for referring to our clinic, but outside of Kaiser and in the past, it's not uncommon for us to hear, you know, I kept bringing things up and everyone would say, she seems fine to me, he seems fine to me. What are you talking about? He's not that bad. And if we don't know what we're working with, it's really hard to kind of put our finger on it. We have this sense that something's going on. We don't get a lot of validation from the outside world. And we can feel really disenfranchised in that role. The other thing that's so important about understanding what we're working with is we really can't set realistic expectations for our loved one or for ourselves if we don't know what we're working with. What's realistic within the context of this diagnosis? How many of you have a diagnosis for your loved one's dementia? You know why they have dementia. That's good news, bad news, right? The bad news is, darn, it really is this. That stinks. The good news is, I'm not crazy. The good news is now I can get as much information as possible and equip myself with the ability to set realistic expectations in the context of this diagnosis. So I don't have time to go into all of the different diagnoses and the subtle nuances between each one, but for purposes of this class, just understanding, getting that really good diagnosis, differentiating what's going on so that you can be well informed, so that you have a little bit more predictability, is huge in terms of feeling empowered and setting up realistic expectations. And I know I keep using that term, and it's because in my experience, most disappointment in life is the result of an unrealistic expectation. So dementia, by definition, how do you define dementia? When you hear the word dementia used, how do you define it? Or you think of, you know, so-and-so has dementia. What does that mean?
Loss of memory, loss of certain skills, loss of comprehension.
Loss of memory, loss of certain skills, loss of comprehension. Yep, those all fit. What else?
Confusion.
Confusion. Hi, come on in. Pardon?
I think depression goes along with it.
Sometimes people can be depressed, sometimes depressed before, sometimes depressed as a result. Yeah.
Delusions.
Sometimes people will have delusions. Does everyone know what a delusion is? A hallucination is different. Delusions and hallucinations are both what we call psychotic symptoms. And psychotic's a scary word because we think of the movie Psycho, but that's not really what psychotic means. Psychotic just means an experience that's out of touch with reality. So a hallucination is an experience that's out of touch with reality that incorporates one of our five senses. So if I see it, taste it, feel it, smell it, or hear it, it's a hallucination, and it's not really there, right? Then it's a hallucination. If I believe it to be so and it's not really true, that's a delusion. So if I see a CIA agent sitting in this chair, that's a hallucination. If I think the CIA is after me, so I have to put foil balls in my hat so they can't send radio waves and read my thoughts, that's a delusion. Does that make sense? One's a belief, one's an experience. All under the umbrella of psychotic symptoms, which can be a feature of some dementias. Sometimes they can be related to medications, but certainly something that we have to deal with sometimes. I define dementia. Now, dementia is not a diagnosis. Dementia is a description of symptoms. In Latin, dementia means the breakdown of the brain, dementia. I define dementia as impaired intellectual capacity, so difficulty learning new things, you know, all of our executive functioning, problem solving, logic, reasoning, impaired intellectual capacity, logic and reasoning, and memory. It's really all of our cognition in, you know, multiple domains of cognition. And if you took our intro class, you learned that cognition is all the different ways of thinking. So our thinking is impaired. Impaired intellectual capacity, lack of ability to use good logic and reasoning, and memory loss. So that's kind of the umbrella, and under that umbrella are the specific diagnoses. So dementia is kind of like fever. I could have a fever. Fever's fever, right? Doesn't matter, she has a fever, who cares why? That's nuts, right? Because if someone has a fever because of an ear infection, that's different than a fever caused by an abscessed tooth, or a fever caused by pneumonia, or a fever caused by the flu. Why does it matter? How you treat them. What to expect in terms of symptoms. What's realistic here? So dementia is the set of symptoms caused by a disease process or injury to the brain. Does that make sense? So knowing the type of dementia that your loved one has can equip you to have even more context for setting realistic expectations, for indicated treatments. If somebody has a Lewy body dementia, for example, we would want to stay away from certain types of medications like antipsychotic medications. And if we don't differentiate, people with Lewy body tend to have intense visual hallucinations, so they might be given antipsychotic medications, which could be contraindicated. So figuring out what our loved one has is a really important first step. And if any of you want more information about your loved one's specific diagnosis, please give our department a call and I can get you more information and we can talk about it. Understanding what we're working with is so important. None of this matters if we don't have context. So the second one here, starting the journey, really kind of refers to kind of getting our head in the game. For a while before we have a diagnosis, even though we know something's going on, there's still a possibility it could be something else. We kind of, now that we have a diagnosis, we know this is indeed a dementia. We're kind of starting on the path. Okay, it is what it is. Now what? So that switching of gears can take a lot of energy. It's empowering and simultaneously exhausting and brings up grief and it brings up a lot of stress. Another thing I think the rest of the world doesn't quite get are the innumerable varieties and permutations of caregiver stress. Let's just list a few of them together. Why are caregivers stressed?
I feel like I have to remember him all the time, like when I have a small child.
She feels like she has to remember him all the time, like when she had a small child. So feeling like your guard has to be up. You have to be hyper aware, hyper alert. That takes a lot of energy. Yeah, what else?
You have to do their memorizing. You know, everything they can't do, so you have to do it, whether it's just take a shower or eat.
Right.
Or, just everything.
Yeah.
So you don't get a second to yourself. You have to be there thinking for them.
Yes. He says you have to do everything for them. You have to do their memory. You have to be their memory for them. You have to do all of their tasks for them. You have to be thinking ahead for them. So often we hear about role reversal. When you're a caregiver, there's a role reversal. And I think in some ways there are reversals in dynamics. If you're caring for a parent, sometimes you feel like you're having to parent them. But I think more accurately, what's so overwhelming is that caregivers are dealing with what we call role overload. I'm doing everything I used to do in this relationship, plus everything you used to do in this relationship. And by the way, I'm supposed to do it patiently and gracefully, graciously, and let you save face and not know I'm doing it. That's a tall order. It's a really tall order. What else is so stressful?
frustration of having to repeat until it clicks.
Frustration, she says, around having to repeat things until it clicks. Sometimes it clicks, and I'm guessing sometimes it never clicks. Yeah. So that's going back to this context, right? Is it a realistic expectation to put on myself the responsibility of helping someone who can't process this information get it to click? And so we get frustrated. Oftentimes I hear I'm frustrated with them because they keep repeating. And I'm also frustrated with myself. And I don't know if this is happening for you, but I hear it a lot. I just can't figure out how to do this right. I get so frustrated and I feel guilty about the frustration. We'll talk about that. But I also feel really inept. I feel like I'm a bad caregiver because I can't get it to click for them. And that creates a lot of stress. There's frustration, simple frustration around repetition because it becomes like water torture. But there's also that frustration that's connected to perhaps some unrealistic expectations we put on ourselves. Dementia is progressive in nature. And the best scientists in the world, unfortunately, haven't figured out a way to cure these diseases. And if we could come up with a way to make a person with dementia remember and understand moving forward, what have we essentially done? We've cured their disease. Because if they can remember going forward and they can understand going forward, then they don't have the features of dementia anymore. And so giving ourselves some slack in the context of this diagnosis, there's so much pressure put on family caregivers. So much pressure put on family caregivers. And, you know, I think it's so important that we talk about all the myriad stresses. I could sit here all day and just rattle them off. Because it's not just the stress around the actual caregiving, which is enough in a vacuum, but it really affects all areas of your life. If you're working, it's stressful trying to balance work and caregiving. Do I need to get some respite care? Am I going to get 25 calls today at work? Is she okay if I leave her alone? Is there a knot in my stomach all day while I'm at work? Am I going to exhaust all my family medical leave and lose my job? Am I trying to maintain my marriage and my family while I care for my parents? And what's the stress there? Did I need to quit my job to care for my husband and now we're financially stressed? I can't go to my book club anymore because I can't leave her alone. I can't golf anymore. I need to go to the doctor myself, but I've had to reschedule my physical 3 times because I can't get there. So the stress really has a ripple effect. And I think, again, the rest of the world doesn't quite get that. And sometimes we ourselves don't get that until we sit down and really take inventory. Oh, no wonder I'm so exhausted. There's not a part of my life this doesn't touch. Oh, no wonder I'm having such a hard time. It's relentless. So the reason I bring up caregiver stress and the next topic, grief and loss, is not to rub salt in your wounds, but to really justify and give permission for caregivers to take good care of themselves. And I'm quite aware of the fact that folks who stand up in front of these rooms like me, we do-gooders, can be very patronizing. When we stand up here and we say, you need to take good care of yourself. Take good care of yourself. You know, you need to take good care of yourself because did you know this is stressful? Of course you need to take good care of yourself. How would you like me to do that, lady? That's what I hear all the time. And so I'm sensitive to the fact that caregiver stress is an absolute risk factor for family caregivers. We know statistically that family caregivers have higher levels of depression and anxiety than their non-caregiving counterparts. We know that family caregivers often have worse health status indicators than the people for whom they're providing care. Does that make sense? Often your loved one with dementia is healthier than you are as time goes by, because they get to their doctor's appointments, you're monitoring their medications, you're monitoring their food, and you've had to put your knee surgery on hold, and you haven't been to your physical exam, and your coffee is still in the microwave. So caregiving is a risk to your health and well-being. That doesn't mean you're doomed. If you cultivate some coping strategies, if you tap into helpful resources when they need them, you're less at risk. And that's why we like to have this class after someone's been diagnosed for family members, because we want to make sure that you're aware that you deserve some support yourself. And so when folks stand up in front of a room and simply say, did you know this is stressful? You got to take care of yourself. That's incredibly patronizing. I was blessed early on in my career. I was 23 and right out of graduate school and doing a support group. And, you know, I've been working with people and families with dementia for a long, long time before that. I started when I was quite young, working in an Alzheimer's day program all through high school, college, graduate school, and I volunteered as a child and really understand this disease, this umbrella, right? Very, very well, but I was a little bit like Gidget comes to social work. I'm 23, and I was facilitating a support group for people caring for folks in early stages. And we were sitting at a horseshoe table, and I was kind of in the center, and the woman right across from me was caring for her mother, who was not an easy mother her whole life. And she was talking about how stressful it was because her mother's previous challenging behaviors did not go away when she got dementia. What happened to them? Can you guess?
They got worse.
They got worse. We call that the morsos. Most often we see magnification of previous ways of being. Sometimes we see a 180-degree shift, but oftentimes we see a magnification, and I'll talk about why. So I'll talk about why when I finish this story. So we're sitting in this horseshoe table, and she's across from me, and she's talking about how difficult it is for her to care for her mother because her mother wasn't a very kind caregiver of her growing up. Her mother was always a little bit controlling, a little bit self-centered, not very flexible. And now she's in a position where mom can't be anything else. Mom's self-centered, mom's not flexible, mom's paranoid because she can't be otherwise in her dementia. And she's talking about how frustrating it is. And, you know, the group is validating that for her and saying, oh my gosh, this must be so stressful for you. This must be so sad. What, you know, where are your boundaries here? Doing all our groupie stuff. And I say, you know, I just got to say, you know, when you're flying on an airplane and the flight attendant is talking about all this safety protocol, and they talk about if the cabin pressure loses, if the cabin loses pressure, oxygen masks will fall from the ceiling. And what do they tell you to do if you're traveling with a dependent?
Put yours on first.
Put yours on first. Why?
Save them dead.
Because you can't help anyone else if you've passed out, right? You're both out of luck. So you really have to take good care of yourself because you can't help anybody if you're not doing well yourself. We can't pour from an empty pitcher. Guess what she did? This was such a blessing. It was such a blessing for me. She slammed her fist down on the table and she said, I don't want to take care of myself just so I can keep taking care of her. And I thought, touche. What are we telling people? That your only purpose, your only good, the only reason for you to be healthy is so you can keep being this caregiving robot? Now, it is true that if your goal is to be someone's primary caregiver, you've got to be in shape to do it. Regardless of how they were in the past, a dependent person deserves care from someone who's able to provide the care they need. I absolutely believe that. I think it's both true that you need to take good care of yourself in order to care for someone else. If it's your goal to be someone's primary caregiver, it's your duty to take care of yourself so that you're in shape to do it. However, it's also your right and your privilege as a human being to take good care of yourself. And if we're only taking care of ourselves so we can keep taking care of someone else, that's just one more thing you got to do. It's no longer self-care, and it doesn't work toward the same purpose. So I was so glad that early in my career I kind of had that shift. I also had that indoctrinated into me while I was working at Redwood Caregiver Resource Center. Again, their whole purpose is helping to support the well-being of the family caregiver. So you, if you worked with them, would be their client, not your diagnosed loved one. And so that was always the message. Because sometimes we face dilemmas where what's in the best interest of the care receiver might not be in the best interest of the caregiver. I think about, long-term care placement. Oftentimes I hear, well, she's not ready for that yet. She's not ready for that yet. But the primary caregiver is falling apart, has hypertension out, off the charts. Their health is in a shambles. Finances are in a shambles. So it might be in the best interest of the family caregiver not to stay in that role, even though it might not be ideal for the patient. And so it gets really, really tricky. So understanding the effects of caregiver stress is really important so that you can continually give yourself permission to take good care of yourself because you deserve to take good care of yourself and because the risk factors are real. It's not selfishness to be self-sustaining. The other trick is, how do we incorporate self-care when we can't leave our loved one alone and we don't have a lot of money for respite and I can't get away and do the things I used to do? So sometimes it's helpful to find someone who can sit down with you or get into a group or sit down and do some contemplation around how your self-care may have to look different now. The way in which you took good care of yourself before might no longer be practical or possible. So we may have to cultivate new self-care strategies that make sense in this new context. And there's a little bit of sometimes approach avoidance resistance there because I don't want to have to do something different. I don't want to be in a situation where I have to adapt so darn much. It's exhausting. Still better to cultivate new strategies than just throwing self-care out the window altogether. A major contributor to caregiver stress are the emotional undercurrents. We all arrive to the caregiving table as the person we were the day before we became a caregiver, with the relationship to the care recipient as it was the day before. That stuff, that history doesn't go away. Family dynamics don't go away. In fact, I had somebody once say that their mother's dementia sprinkled Miracle-Gro on all of their family dynamics. Because everybody has a little less margin. If this is my breaking point, and all this stress is bumping me toward my breaking point, and I'm operating here, it only takes that much for me to break. Whereas if I could get my baseline down to here, the same amount of stress certainly affects me. It bumps me from here to here, but I've got some margin. When everybody's emotions are raw and we're close to our breaking point, those dynamics do tend to come out of the woodwork and magnify. So that's when we talk about cultivating realistic caregiver self-care, what we're talking about is figuring out a way to get your baseline a little farther away from your breaking point. And what's realistic now? We're not talking about being Pollyanna, living in la-la land and no longer finding this challenging. We're just talking about building a little bit of margin so that it's a little bit easier to tolerate. Does that make sense? So when we talk about grief and loss associated with caregiving, you know, when I'm presenting to other professionals, a lot of people get that. They get that it's sad to have a loved one with a chronic degenerative illness. But they don't usually get, in the same way that caregiving stress has this ripple effect and permeates every part of your life, they don't really get that the same is true for the grief and the loss. It's not just the grief around watching your loved one's cognition and functioning decline. That's a major one. I'm not minimizing that. It's major, and it's one of many. There's also grief and loss around changes in your relationship, changes and losses in relationships with other people. I can't socialize with my friends as often. My siblings and I are butting heads. My husband's gonna leave me if I can't figure out a way to be home more often because I'm over at my folks' house all the time. Grief and loss associated with your hope for the future. These were supposed to be our golden years. And now look, this isn't fair. Grief and loss associated with my own sense of freedom, my own sense of health and well-being. I could sit here all day. So the grief is deep and wide as well, and oftentimes it's latent. A lot of times when I'm working with a family caregiver, they understand they might be a little more exhausted. They understand they might be more irritable. They understand that you know, their temper is a little short. They feel guilty. They don't always understand they're grieving because our culture doesn't have a real good context for grief except around bereavement and death. And so, you know, the framework I work from is this framework of what we call ambiguous loss and anticipatory grief. What we mean by ambiguous loss is this sense of loss that's not clear-cut. Our loved ones are both here and not here. Simultaneously here and not here. So what do we do with that? And for some people, the larger question, what does it mean about me if I'm grieving and he's not dead yet? Does that mean I gave up? What does it mean about me? So understanding the context, again, is so important. When somebody is simultaneously here and not here, the ambiguity of our sense of loss makes a lot of sense. And for those of us in the do-gooding world who think we know everything and like to give a lot of advice, friends, family included, right? Understanding that ambiguity often causes ambivalence. So how many of you find yourself in the position of just not knowing what to do a lot of the time? Well, sometimes I think, just today, huh? Sometimes I think I think we need to do A. But then something changes, so then I think, oh, not A. Maybe I am making too much of this. Maybe my brother in Colorado's right, and I've just always had a hard time with Dad, and I'm just looking through it with that lens. And then maybe A makes some sense now. Okay, I want some help, and I call and ask for help, and then the helper finally calls me back a week from now, and then I say, oh, never mind, I don't need that anymore. And then because things have changed and I'm on B, and then everyone around you thinks you're resistant, you're in denial. You need to take good care of yourself. You need to look into respite. You need to do this and that. Anybody feel like you don't know what you need to do? That's really normal when the situation is so unclear. Ambivalence is a normal response to ambiguity. So when you find yourself not quite knowing or feeling like you're second guessing yourself a lot of the time, rather than being judgmental of yourself, which just adds to your stress, recognize that that's normal in this context. And if you have helpers who seem like they're getting frustrated with you, maybe you can throw this phrase at them. Maybe you can help educate them. Look, I know I seem really wishy-washy, but it's not because I don't want to do something productive or proactive. It's because the situation is a moving target. My loved one's both here and not here. And that's really hard for me to hold. I don't even know how to feel about that, let alone what to do with it. Does that strike a chord? Does that make sense? Yeah. The other way that we see grief manifest that's a little bit different than how we see grief manifest if someone dies is this anticipatory grief. Kind of that sense of waiting for the other shoe to fall. Does anybody have that sense sometimes? Okay, I know everything's okay right now, and if nothing changes, we're okay, but I just can't let my guard down. Well, what am I going to do if that happens? Or when is this going to happen? Or is this going to happen? I'm being, I'm having little losses all the time. Maya Angelou once compared something, and some of you have heard me say this before because, if you've been in other classes, I use this analogy a lot because it's a mental image that makes a lot of sense for me. Maya Angelou once compared something to being pecked to death by ducks. I can't even remember what she was talking about, but I was listening to one of her lectures, and she was saying, yeah, it was like being pecked to death by ducks. And if you think about it, ducks don't have sharp bills. It takes a lot of repetitive, constant pecking away to be pecked to death by ducks. And that's kind of my mental picture of anticipatory grief. Just little losses over time. So when folks think there's something wrong with them because they should be over this by now, I've been caring for him for 8 years, you think it wouldn't be so hard for me. You think I'd be over this by now. It's such a different animal. If your loved one had a massive heart attack and suddenly dropped dead, that would be enormously traumatic, and you would have a lot of grief associated with it. So please don't leave today and hear and say, hear me say, that's better. It's not better, it's just different. It's clear cut. We know what happened. They had a massive heart attack, they died. There was an event. So 8 years later, I am more accepting. I have incorporated that. I have coped with it. But when you're constantly being pecked away, it's still happening. How am I supposed to get over something that's still happening? It's not that I don't know how to heal properly, it's that my scab keeps getting ripped off. Does that make sense? And that's what anticipatory grief looks like. That sense of waiting for the other shoe to fall. So again, I bring these things up not to be rubbing salt in wounds, but to really validate. And hopefully, if you're feeling any of these things, normalize that for you in this context. This is really hard because it's really hard, not because you're flawed. Now, there are always ways that we can look at how we're approaching and how we're coping and learn ways to, not add extra stress to a situation, right? There's always ways to get some help and identify, oh, maybe I could make this change, or maybe I could make that change. How might I be having some unrealistic expectations? So that doesn't mean we can't make positive changes and cope, but my point is the very nature of this circumstance is incredibly complicated and incredibly difficult. So if you're challenged by it, that's what I would expect. It's not you're challenged by it because you're not a good caregiver or, you haven't figured out the right way. Does that make sense? Is that helpful? So I am going to switch gears now because I think that's enough of that, but I would be remiss if I didn't talk about that. And I think that that's where, we're going to transition into talking about working with your loved one's healthcare team. And I think, again, that's where the rest of the world can be sometimes disrespectful, not intentionally so, but disrespectful of the family caregiver's experience. If I were to come and teach a class, and I do here, come and teach a class on understanding certain strategies for working with people who have dementia, right? So working with difficult behaviors or communication strategies. And I just came and I rattled off all these steps, but I didn't validate and understand and have sensitivity around how difficult it is to employ those steps. I think I would be inadvertently disrespectful. I don't think anybody in the profession who teaches a class and doesn't do that is disrespectful on purpose. But I do think it often doesn't occur to us. It's not so easy. It's not just here are 10 simple steps, now go and have a great time and be warm and filled. The strategies you will read about in any book and that you will learn about in any class are pretty common sense. They're pretty simple strategies. But simple is not synonymous with easy. Simple just means they're not complicated. But they can be quite difficult to employ for all of the reasons we talked about before. How many of you want to need this class today? Nobody wants to need to adapt their approach with their loved one because their loved one has a chronic degenerative diagnosis. So cultivating new skills is simultaneously liberating and empowering, because I can learn how not to add fuel to the fire. I can learn to have realistic expectations. But it's also very, very sad. It brings up a lot of grief. Every time I adapt the way I interact with my loved one, it requires me to grieve the loss of the old way of interacting and the loss of the hope that I'll ever be able to get back to that old way. So when we come to this place of acceptance, yeah, it is what it is. That's a tricky place. We're starting the journey. We got our heads in the game. But who wants to be in this game? Nobody. That's right. So I'm sensitive to that when I'm teaching these classes, when I'm providing education to other professionals who work with family caregivers. And I hope that you'll be sensitive and gentle with yourselves as you are challenged and grapple with cultivating new strategies. The strategies are simple to do, they make sense in the context, and I hate that I need them. I see some nodding heads. Give yourselves a lot of credit. Look at all of you here in this room today. And nobody raised their hand saying they wanted to need this class. Yet here you are. Here you are. It's not lost on me the enormous effort it takes to get to these kinds of classes. Some of you had to arrange for respite care because you couldn't leave your loved one. Some of you had to take time off work. You had to drive through who knows what kind of traffic, deal with the parking, right? It's no small feat to get here, and here you are. So give yourselves ceaseless credit for working toward cultivating these strategies. My goal is not to turn people into perfect caregiving robots. My goal is to help people be a little bit more aware of where they have control and where they don't, to be gentle with themselves and realistic in their expectations. So in working with the healthcare team, how many of you found that really easy? No?
What are you referring to when you say the healthcare team?
Great, and that's my next question. You're gonna think she's an audience plant. She said, what am I referring to when I ask about the healthcare team? Before I jump into that, since nobody raised their hand, is anybody willing to share some challenges you've had without using specific names?
Through the system here?
Through just kind of what challenges working with the healthcare team. It's actually good insight for us. And I think it's probably true across the board no matter what system you're in.
I think that it's partly our fault. My mother-in-law was with us.
Mm-hmm.
Partly our fault because we were, putting blinders on, and just she lived with us,
Mm-hmm.
so we took care of her,
Mm-hmm.
and kind of not noticing, really specifically how things were deteriorating. So I would say a few things to her primary care physician, but I think I wasn't being, totally acknowledging of what was happening.
Right.
So I couldn't really convey to her. So part of the slowness of getting to this point had to do with that.
With your understanding of what was important to
Right.
report.
But
Yeah.
there was when it clicked.
Yeah.
With whatever I happened to say that the last time, things moved really quickly.
Good.
And efficiently. We
Good.
got right into the first class,
Mm-hmm.
and then the meeting with the doctor.
Good.
And you.
Good.
And
Good.
so, and then I've gotten calls from, I guess, your referrals to
Good.
places. So
Good.
it's a good experience once
once you
I
got
know.
here. Yeah, good,
You know,
good.
but you guys couldn't know until, we come out.
So you're touching on another point that I want to make. I think a lot of times it is difficult. You said it was hard because you didn't quite feel like you were able to convince the primary care doc that there was a problem. That's kind of, and some of that you're saying is because you didn't quite know how to, you weren't conveying it because you didn't know what to look for. Yeah.
Well, but also there's a lot of denial.
Yeah, so some denial and minimizing. And if you don't know what's normal, what's not normal, we think, oh, well, she's such and such age. Isn't that just normal? Yeah. So there's that piece, but then there's also this piece around folks not quite understanding how the animal of dementia plays out. So going back to this overview of dementia, remember I said dementia includes impaired intellectual capacity, logic and reasoning, and memory. But what a lot of people don't recognize is that dementia, most people with dementia also maintain instinct, intuition, and emotion. And that's a blessing and a curse. The blessing is oftentimes people can still interact in familiar settings. They maintain their social graces for a long time. They can be humorous and funny and sometimes even let their guard down a little bit more, so they're even more gregarious than they used to be sometimes. And so we often hear, as I was mentioning before, well, she looks fine to me. Oh, she seemed okay. One time years ago, I was a social worker in, I used to do moonlighting at an emergency room. And I remember someone saying to me, oh, well, she's, daughter says she's demented, but really she knows she's in the hospital. She's not that confused. And I said, well, she knows she's in the hospital because of the IV and the machines and the doctor and your lab coat, but will she remember she talked to you when you leave the room? Will she remember she was here? What is she an accurate reporter? What is the daughter corroborating the story? I myself was doing a home visit one time, and I know dementia like the back of my hand. I was doing a home visit one time years ago, and I remember sitting at someone's dining room table. I was talking to someone who was caring for her husband who had dementia, and he came down the stairs and sat down at the table and talked with us for a few minutes, and then he excused himself and went back upstairs, and I looked over at her and I said, gosh, it seems like he's having a good day today. And she started chuckling. And I said, what? And she said, yeah, seems like it, except not one thing he told you was true. So there's a difference between presenting well and actually functioning well. So lots of people tend to fly under the radar screen. And I think that's why it takes a while to get to a specialist, not just here, across the board, because people can present really, really well. That's why when your golden boy brother flies in from Colorado, visits for half a day, and then leaves and says, I don't know what you're talking about. Or when your uncle calls and talks on the phone for 15 minutes and says, he sounds just fine to me. Or somebody from the bocce ball club says, well, he remembers everybody from high school. I don't even remember those people. You're ripping your hair out. Presenting well versus actually functioning well. Two very, very different things. So that's one of the challenges, kind of what do I need to tell the healthcare team? I see you. What do I need to tell the healthcare team? What's important for people to know? You had a question.
It wasn't something you brought up earlier, but you don't want to hurt their feelings or confront them with the reality of their situation.
Yeah.
So, you have to talk about them when they're not there. And
yeah. It can sometimes turn into this crazy covert operation.
Yes.
And then you wonder who's crazy, them or me. I'm doing all this sneaking, I'm talking to, you know. And then the other thing that can sometimes be stressful, has anybody ever had the experience of having a healthcare professional say, I'm sorry, I can't talk to you without their permission?
Mm-hmm.
So then we have HIPAA. And I love HIPAA, I think it's great. I want people's privacy protected. HIPAA prevents us from giving private health information without permission. It does not prevent us from keeping our mouths shut and listening. It does not prevent us from reading a note you send. You might not get a call back from us because we might not have permission if you don't have a power of attorney or something signed saying we have permission to talk to you. But doing this behind the scenes stuff can be tricky. That's one of those things where first time you have to do it, that shifting gears, okay, now I'm empowered to get this information to this person who might be able to help us. But gosh, I can't even believe I'm in a position where I'm having to do this. This feels like the Twilight Zone. Then the grief comes up. Oh my gosh, we're really in this. I really just called and told the doctor to ask these questions and pretend like I didn't say anything. It takes my breath away. So every time we adapt our approach, every time we become more empowered, the necessity for that adaptation brings up grief. Does that make sense? So be really gentle with yourself. So I'm coming back to your question here, because this is my question to you. Who is the healthcare team? Do you all know, now that you're connected with the geriatric medicine department, do you all know who's on your loved one's healthcare team? No? I am, yes, and who am I? I'm the social worker, and my role is to check in with you and see how things are going, to see what resources you have in place, what resources you might need. How are you coping? Do you need information? Do you need support? How are things going? What's in place? What's not in place? How can we help support this family system? Is everybody safe? Is there a plan in place? Do we have all of our T's crossed and our I's dotted to the extent that we want them? That's kind of my role. Who else? So social worker, the doctor. So the geriatric medicine doctor. Who else?
Pharmacist.
The pharmacist. Yes, we have a pharmacist on our team. We know that older adults metabolize differently than younger adults. We know there are medications that are often contraindicated for folks who have dementia. We know there are certain medications that can affect cognition. And so our doctors and our pharmacists work really closely together to monitor the medications that folks are on, to make sure there's nothing going on with those medications that could be complicating things. Pharmacist is a really valuable member of the team, and a lot of people aren't aware how to use the pharmacist. And a lot of people aren't even aware that we have a pharmacist on our team. So kudos to you for knowing that. Who else?
I have a question
Sure.
concerning the pharmacist and the connection between, the family physician. Because we're still going there too. And are they made aware of what?
Yes. So the family physician sees all of the notes from the pharmacist.
So for instance, we had to go to the family physician for a back pain and a medication is prescribed, and I'm picking it up. But am I assured that the geriatric team pharmacist?
It is not. I wouldn't assume he's notified every time your loved one gets a new medication from any doctor. I would call the pharmacist and say, she's getting this new medication. Is it okay? And before you do that, have all of you gotten our caregiver handbook? Do all of you have that caregiver handbook? So at the end of that, under the medications tab, there's a list of medications that are contraindicated. So bring that list with you to those other appointments, and if a new doctor prescribes a new medication, you can check that medication against that list and ask the doctor, is there something else we could try, or is this still the best option in light of the risks? With medication, it's always risk versus benefit. But you could always call our department and say, I have a question for the pharmacist. Absolutely. So, geriatric medicine doctor, social worker, pharmacist, who else? We have a nurse. So you could call in and talk with Michelle, the nurse. Some of you met Michelle when you took the introduction class. She generally teaches that class. Some of you may have been in the class that I taught. Yeah. Primary care doctor. In fact, the primary care doctor, lots of times I get calls and I say, that's a question for your primary doctor. Primary care doctor is kind of overseeing all the other health issues. And other specialists. Who else? Hearing, eyes, so all those other specialists. One big one missing.
Memory. Support group. We've been getting tons of calls and information since he was diagnosed when we went to that first class. Just letting us know that they're available.
Good.
But we don't feel we're at the point to need their services.
Yeah.
Yet.
So we have community partners. We partner with the Alzheimer's Association and Redwood Caregiver Resource Center. So ordinarily when your loved one is diagnosed, we have you fill out that release to have us fax a referral over to those partners so they can get in touch with you and offer support as needed. It's always as needed,
right.
But we would love for folks to just be aware and plugged in. So certainly our community partners. The big one that I haven't heard is you. How many of you understand that you are a part of the healthcare team for your loved one? In fact, you're a very, very important member of the healthcare team. That's why we meet with you. The doctors meet with you when you bring your loved ones in. I meet with you when you bring your loved one in. Sometimes the pharmacist meets with you when you bring your loved one in. We understand that you are the person who knows the patient better than anybody else on this planet. And so we want to hear from you your observations, your concerns. We want to verify your story and their story to see, are they tracking? What's like the woman who told me, yeah, but nothing he told you was accurate? We understand you are probably going to give us a more reliable report of the situation than if we had you stay in the waiting room and we just talked to your loved one alone. There's a difference between functional capacity and level of impairment. And I think, too, that's another thing, where people don't recognize that, people might be more impaired than they present. And so often families, again, ripping out their hair saying, something's wrong, there's something very, very different here. Oh, well, she scored really well on her test, so there's nothing wrong. Or family saying, well, he's still doing all right with that, so we made a few mistakes. He's 83, what do you expect? Functional capacity is what can you do? What can you do right now? And that's an important piece of the picture. But we need to know that against what you used to be able to do. What was your baseline functioning? So if your loved one was a NASA physicist and now made 3 mistakes in their checkbook register in the past week, that's pretty significant. They were a NASA physicist and now they can't even do basic arithmetic. And I say to you, oh, well, that's okay. I made a couple mistakes in mine last week. And you say to me, you don't understand. This person has never made a mistake in their checkbook register in the 45 years that I've been married to him. That's significant information for me to know. If this is somebody with a 3rd grade education and they've made some mistakes in their register, that might be less significant. Does that make sense? What were they previously capable of and what are they capable of now? That's the level of impairment. So you might leave, and some people have left with a, oh no, they're not, this testing doesn't suggest dementia yet. Maybe there's a mild cognitive impairment, or, this just still looks like normal aging so far. And you might leave frustrated saying, and there's certain criteria that have to be met for a dementia diagnosis. You have to be in a certain threshold. But it doesn't mean that your loved one's not impaired from how they used to be. Just means they haven't met that threshold. Does that make sense? So we really want to hear from you. That's why we have you do the pre-visit questionnaire when you come in. And that's why we want to meet with you when your loved one comes in for their evaluations. Because we know you're the expert on our patient. And you're part of our team. We rely heavily on your expertise of your loved one and what you're observing. So remember that. When you're advocating for your loved one, when you have a question, we really welcome your questions, we welcome your insight. And just because, sometimes we might not recommend doing something about something, that doesn't mean we don't understand there's a change or understand you're concerned. So it's always okay to ask questions and get clarification, and it's always okay to offer information. One thing that makes that, we're moving on to point number 6 here, one thing that makes that more facile to do is having legal planning in place. And what I mean by that in terms of our purposes is an advanced healthcare directive. Or at least, usually we have a release of information authorization on file. That allows us permission to talk with you about what's going on. The advanced healthcare directive actually allows someone to appoint a medical decision maker for them. So if your loved one gets to the point where they can't consent to treatment, who has permission to consent for them? Does everybody here have a loved one who has completed advanced healthcare directives? And if not, we have information about how to get those things done. I actually brought some packets today. We have workshops taught here at Kaiser. I have some fact sheets on legal planning for incapacity. You have a question?
I have a question about whether she had a living trust, and in that there's a medical.
Mm-hmm.
Is that good for what you're talking about?
Yeah, if there's an advanced healthcare directive as part of the living trust, we wouldn't need the whole trust. But if you bring in that portion that talks about healthcare wishes and the appointing of an agent, we would love to have that scanned into everybody's chart so that we know this is the person who is allowed to consent for treatment. We can talk to all kinds of people just by having that authorization signed, but the person who's allowed to consent to treatment is the healthcare agent. Does that make sense? And did you have a question?
Yeah, it does not. The booklet, though, we filled it out, and then we had to change his address.
Yeah.
And membership said no, they could not have that. I had to have the power of attorney
redone.
I had to have it from the lawyer saying I had power of attorney to change the address.
To change the address.
The booklet did not give me that.
Well, that is a question for The life care planning team, and also a legal question for member services. I don't know about changing addresses, but that's yeah, I'll have to look into that. Yes.
Power of attorney is totally different than that.
The healthcare power of attorney. This appoints a decision-making agent.
Yes. That's what they said. They said I could
So
do anything with you guys.
the healthcare decisions, but changing the address, you have to have a different power of attorney. Yeah, yeah. So you may want to tap into some legal resources with some of the, good. Some of the partnering agencies, and I have a list up here, various agencies that offer senior legal services, estate planning, long-term care planning, through an elder law attorney who really is well-versed in these things. I'm not an attorney, so I can't give legal advice. I can say it's important to get good legal advice and have good legal documents in place. Another thing that's really important is to make sure that those legal documents are current and relevant to the situation now. Because if your loved one filled out, you and your husband filled out advance directives in 1984, and you were both listed as decision makers for each other, but now one of you has dementia, you may want to pick another agent if you don't have an alternate listed. And sometimes people don't think about that because there's so much else going on. So making sure that if you do have previous documentation in place, pulling that out and making sure it's relevant and current to the situation now. The other thing that's really important is financial planning. As things go forward, how are we going to finance long-term care? Do we have long-term care insurance? Could we qualify for Medi-Cal for long-term care? Are there VA benefits we could tap into? Do we want to try to hire in-home help, or do we want to look at outside of the home? And at what point? So, I always recommend, because this is an ever-changing path, having some concurrent plans in place. Well, my goal is, and I assume everybody's goal, unless they tell me otherwise, is to try to keep my loved one home as long as possible and adding in support as needed and considering a long-term care placement only if I can no longer manage or maintain the level of care they require at home. That's my assumption about most families. Some families have different plans in place. But sometimes as long as possible is this long, and sometimes it's this long, and sometimes it's this long. And sometimes things happen that speed up that as long as possible boundary. So we're crossing into that boundary now where it's no longer practical or possible to maintain this. Somebody falls and breaks a hip, somebody has another stroke, somebody has something happen, I fall and break my hip or my wrist, or I just get to the point where I can't do this anymore. We're going to talk about that. And so my advice for anybody, and sometimes my job is to bring things up that nobody wants to talk about, but my advice to anybody is to start looking at alternatives before they're on your horizon, before the need for them is on your horizon. So start thinking about long-term care. What is available? How would I finance it? Who can help me with that? What are good questions to ask? What resources do I qualify for? So our partnering agencies, that's one of the things that Redwood Caregiver Resource Center can help with. When you meet with a family consultant there, they'll do an assessment of you and your needs and help you come up with an action plan with steps. So they might give you some information about, long-term care planning. They're asking all of those things. I try to ask those things when you meet with me. I can't spend the time with you that they can spend with you. So if you've met with me before, I'm usually sending you to Redwood or to the Alzheimer's Association, oftentimes both. So getting good support and having a plan B and C and D, at least the scaffolding of those plans in place. So if I need to make this change, here's where I go to get help with it. If we need to start looking at residential care, these are my options, and these are the people who can help me with it, and these are my options for financing. So you don't have to have everything in place. Again, my goal for today's class is that you understand there's help out there and how to get tapped into it, and to tap into it sooner than later. If you need help tomorrow and you call today, you might be on a really long waiting list. So getting plugged in, even if you don't need help, so that you're established, can be really, really helpful when and if you do need services and support. Does that make sense? Okay. Number 7 here, when my colleague and I were writing the curriculum for this class, we both agreed really strongly on this one, Plan B. It's really important to be able to feel like, again, you have alternatives, you have options. So the only times people in my career have gotten upset with me are when I've suggested they take care of themselves. We know why, we talked about that one. The other one where folks sometimes tend to bristle is when I suggest they have a choice about caregiving. Because for a lot of people, it doesn't feel like there's a choice. For a lot of people, it feels like this just fell into my lap. And so understanding that there's choice, you don't have to be stuck in this role if you don't want to be in this role anymore, is really important to be aware of. And when you're aware of that, then every day that you stay in this role, you're in an empowered position. You're not continuing to be a caregiver because you have to, because there's no choice. You're continuing to be a caregiver because you've chosen for whatever reason. And I'm not trying to, again, be patronizing and say, oh, caregiving's so lovely and meaningful and your heart's going to be so expansive. It probably will be after, down the road, when you have some perspective. In the thick of it, it doesn't feel that way. My suggestion is tap into what is meaningful for you. If you have 4 brothers and sisters and none of them is helping but you're the only one doing the caregiving, how come it's okay for them to have boundaries? Why are you in this role? And for some people, it's because I want to keep him out of a facility. Good. So hold on to that. This is really, really, really hard, but it's meaningful for me to do it to keep him out of a facility. And then we talk about what's realistic as time goes by, right? Sometimes it's, I took my vows very, very seriously, and I want to stick in this as long as I can. That's good, that's meaningful. Again, as time goes by, we have to look at what's realistic. There are always alternatives. Often the alternatives are unsavory. And that's why we choose option A. But when we don't recognize there are other options, that's when we feel trapped. There may come a time when we have to employ option B or C or D, and it's not an option we wanted. At the point at which we have to employ those, it's because option A is no longer working. Does that make sense? Feeling trapped is probably the #1 reason I hear for caregiver burnout. I just feel trapped. I just feel trapped. I don't have any options. There's no alternatives. I didn't want to be doing this, and I feel trapped. So understanding what the alternatives are, how to access them, and getting support around deciding whether or not to access them can be really helpful. Just having Plan B in your hip pocket can help alleviate that feeling of being trapped. We may never have to employ Plan B, but knowing I've got one can relieve a lot of pressure. If something happened to me tomorrow, I have some kind of idea around what we might do. Most people are comfortable with that one. What about if you wake up tomorrow and you say, I don't want to do this anymore? I think that's fair enough too. Most people aren't comfortable enough to give themselves permission to say that, but it's okay to say, I put in X amount of time and I put in a really good run. And now I'm starting to notice the effects of this stress, and I want out of this primary caregiving role. That doesn't necessarily mean I want to abandon my loved one. I never want to see them again. I don't want to be involved at all. It's okay to say I no longer want to fill this role. It's as okay as saying I no longer can fill this role. When people come to me and tell me I'm done, I believe them. I think that's another thing that, sometimes can be really tricky on caregivers. The rest of the world is so patient focused that the whole, everyone at the planning table is planning for what's in the best interest of the patient while the caregiver is limping on the wayside. And if the primary caregiver is limping along on the wayside, I got to tell you, that's not fair to them, but it's also no longer in the best interest of the care receiver. That's when we start to see, care decline, sometimes some benign neglect that has kind of a slippery slope. That's when we start to see people reaching the end of their limit, because a rubber band that's stretched far enough will eventually snap, guaranteed. So when people come to me and say I'm done, I believe them. I don't try to talk them into toughing it out. And I honor it. I think it's a really good judgment call. Most people don't. Most people figure out ways to stick in the game and get support and find meaning in it, even though it's really difficult. But if you need to make a change, and there's a big gray area between doing everything by yourself with no support and being done. Hopefully, if you can tap into some resources and support, you'll be able to stay in this role and tap into what's meaningful about it and feel good about yourself while doing it, because you're using realistic expectations, you've got support, you've got some breaks. So within that gray area, getting some help, some respite care, day programs, temporary vacation with other family members, time off, support groups, counseling, all kinds of help. But if you decide for whatever reason it's no longer feasible for me to be in this role, I say kudos to you for making a good judgment call before there was a calamity. Before you got to the point where you could no longer provide objectively good care anymore, before you got to the point where you became a casualty of your loved one's diagnosis. So let's put our heads together and see how we can keep your loved one getting the good care that they need and help move you out of this primary role. That's possible. Understanding that I get to have a plan B, like I said before, can take a huge weight off of people's shoulders. So if you haven't given yourself permission to contemplate a plan B, what would I do if I couldn't do this anymore for whatever reason? What would I do? What's the plan? And what resources do we have? What resources might we need? And who can help me with this process? I mentioned before I used to moonlight at an emergency department. One day I was there. I used to show up after. I worked at Redwood during the day, and I would show up after work and work in the evening when I was crazy and thought 2 jobs was a good idea. And I showed up one day, and the charge nurse just met me. She was like, she's watching. As soon as I walked through the door, she met me. She was this close in my face, and she said, "You'll never believe what happened." And I said, "What?" She said, "We just had somebody just dumped their father here today. Just dumped their father here. Can you believe it?" She was incensed. She was so upset. "Can you believe it? That's elder abuse. That's abandonment." And I said, "Oh my gosh, what happened?" She said, she just came in with him, sat down with him, and then she just got up and left. There was a note pinned on him. She left a note pinned on him that said, "Please take care of my dad. Please keep him safe. I can't do it anymore." Can you believe it? Can you believe it? It took 4 of our male staff to wrangle him into a bed, and that's where I knew I had her. I said, "It took 4 of our male staff to wrangle him into a bed? No wonder she can't do it anymore." I said, "We have no idea. We have no idea what led up to this. All we know about her is she wants her father to be safe and well cared for, and she brought him here. Now we have a symbol on the front door with the stork carrying the baby, that universal safe surrender symbol, where we welcome people to bring their newborns and drop them off if they can't care for them anymore. And we say, kudos to you for your good judgment. Thank you for not abandoning your baby, out on the street somewhere. Thank you for bringing them to this safe place." And when this woman did the same thing with her father, who weighs 185 pounds and is incontinent and needs to be wrangled into a room by 4 people, 4 men, we vilify her? What message are we sending? Now, I share that story because that was not a good plan B. I'm not saying do this. Please don't do this. Please don't do this. But this woman, had she tapped into resources, had she had other support, had she given herself permission to have a plan B, had she been aware of folks who could help her strategize alternative plans and gotten support around needing to put those plans in place when her guilt came up, she may not have needed to resort to this. But I withheld all kinds of judgment because I think regardless, she kept him safe. We don't know if he was a nice father to her whole life. We don't know if she's exhausted her FMLA and going to lose her job. We don't know if she has 3 small children at home that he's hitting with his cane. We have no idea what led up to this. All we know is she brought him to a safe place and asked that he be kept safe.
Excuse me.
Yes.
Unfortunately, I do have a doctor's appointment at 12.
That's fine.
It's a very good class. Very
Thank you. And if you want any handouts, feel free to just come up and grab some. You have. Okay. Take care. Mm-hmm.
Thank you.
So my point with that story is the more we give ourselves permission to start strategizing on the front end, the less likely we are to get to that place. I bet my bottom dollar that daughter did not feel good about herself as she walked out of that emergency department. I bet she felt really, really bad about having to resort to that. And I still give her credit for keeping him safe. She could have done a whole lot of other things. Nobody wants to have to feel like that's their only alternative. And it's not your only alternative most of the time. I live in the real world. Sometimes we have to do a Hail Mary. Most of the time, those Hail Marys are the result of not tapping into services earlier on. When I recommend supportive services at an initial appointment, I understand it's a lot coming at you all at once. Sometimes I bring up things that you haven't even had on your radar screen yet. And so again, the purpose of that and the purpose of our handbook is to plant the seed. There are resources. There is help. Please ask for this help as you need it. It's not meant to cram all of these services down your throat all at once. At the same time, I often stress the importance of tapping in earlier on with safety things, with care for you as the caregiver. The number one thing I hear from people over and over again is, I don't think we're at that point yet. Oh, I don't think we're there yet. And that's good. However, the time to plan, the time to access the support is before you need it. Once you need it, it's really hard to get your head above water long enough to do the legwork to access the resources. Does that make sense? The other thing I'll say, and this is just because systemically, nationwide, there's never enough help. There's not enough help under the sun. And there's not a lot of funding for lots of these programs. And my point in saying that is sometimes things move a lot more slowly than we want them to move. And when we present at different agencies or programs and we need help yesterday, sometimes they don't have the ability to mobilize that quickly. So tapping into resources earlier so your foot's in the door makes it more likely that when and if you need these services, you can get them more timely. Does that make sense? Don't bring these things up again to poke at your tender spots. I bring these things up so that you can be empowered and equipped to tap into help if you need it. We're not in the business of making people too safe too soon. We don't want to upset the apple cart if it's not necessary. If everything's going well and you're not at that place yet, great. So you call and say, I want to get on your mailing list, or I want to call and just do a basic, initial meeting with you to see if there's anything you can identify. Or I just want to look at what my options might be for long-term care financing. We may never need to put Plan B into place. I may never join a support group. I may never need counseling. I may never, my loved one may never wander. But if those things happen, I know how to get help. A big one is that safety bracelet, right? I say that one all the time. The safe return bracelet. Oh, well, she's not wandering. That hasn't happened yet. And I usually say, well, we want people to have it on before they wander, because it's not going to help them if they wander and they don't have it. So it's about prevention. All of this is about prevention. Not preventing the stress, not preventing the need for help. I think that kind of comes with the territory. But preventing that Hail Mary from preventing getting to the place where, as you said, she cracked. From preventing you from becoming among the statistics of people who have their health and well-being affected by caregiver stress. Determine not to let it make you crack. And that might mean you need to get some support around having healthy boundaries for yourself. Everybody wins if you do that. Everybody wins if you do that. It's easy for me to stand up here and say and suggest because it is hard. I think oftentimes it has to get harder before it gets easier because it takes a lot of time and energy to do this, take this inventory, to set up meetings, to look at what we need, to know how to say what we need. It takes a lot of effort. But I've not heard one person tell me, gosh, I really regret having a plan in place sooner. I've had lots of people saying, gosh, I wish I knew about these guys 5 years ago. Gosh, I wish I'd called you when I was caring for my mother. Gosh, I wish I knew about that service. So where to now? Now you're all established in our department. So between your loved one's follow-up appointments, we're available to consult. You can send us secure messages to the doctor, to the nurse, to me. You can set up appointments with the nurse, with the pharmacist, with the doctor over the phone. You can call and talk with me if things come up and you have questions about managing difficult behaviors or managing communication issues or resources or challenges. So we're available to support you between your loved one's appointments. Don't feel like you have to wait to talk to one of us until 6 months from now when you come in. Tap into, or at least make yourself educated about community resources. Most of you already have. If you've met with me, I gave you this list of resources. There is a list of resources in your caregiver handbook. Many of you have already been referred to our partner agencies, Redwood Caregiver Resource Center and the Alzheimer's Association. If you haven't heard from them yet, it's probably because, you know, they get referrals from everywhere and we send them stacks of referrals every day. So just because we sent over a fax, if you haven't heard from them yet, there's nothing that says you can't call them and set up an appointment yourself. If you don't have legal planning in place or you have questions about your legal planning, we have a life care planning team here. This talks a little bit about the program, and there's also a schedule for the workshops that they teach. One of the life care planning social workers, an elder law attorney, and a notary are all present at these workshops. So if you have questions, you may want to come and get one of these. If you don't have advanced healthcare directives, or if your loved one doesn't have an advanced healthcare directive on file, I brought the packets today, so you can come up and grab one of these. This is information on legal planning for incapacity. I have information here on Veteran Service Office, so if you have questions about, you know, if your loved one's a veteran and they haven't tapped into VA services and you have questions about their eligibility, or if your loved one is the widow of a veteran and they may be eligible for survivor's benefits, it might be helpful to tap into the VA and call the Veteran Services Office to see what they may be eligible for. I have all kinds of other fact sheets up here: hiring and home help, caregiver health, tips on caregiver self-care. Please feel free to come up and get some handouts. Thank you all for being here today. I hope this was helpful. I hope it planted some seeds for you and you have a better idea around why you're feeling as challenged as you're feeling. I hope it feels, you know, that you feel more normal in that challenge for this context, and that you understand you're a valuable, valuable member of your loved one's healthcare team, and we are available to provide support to you ongoing. Please, please keep in contact with us as needed. Thank you all. Take care.